Look, thanks, Mark, and thanks everybody. Really kind introduction to talk to you today about this really interesting nexus, I think, between TB and COVID and antimicrobial resistance. Pure coincidence, but I've come here from. I'm on clinical ward service at the moment, dealing with both someone who is COVID and TB co-infected and someone who's arrived from India with what we would colloquially term totally drug-resistant TB. So a lot of international emails about how all of these things come together is pretty live from me today. In this talk, what I thought I'd try to do is to start by reflecting a little bit on the impact that COVID has had on TB services, both in Victoria and globally, because they've both been significant but also quite different. And then after that, I'll plan to circle back to some developments in TB public health, which are particularly in relation to whole genome sequencing, which have developed independently and in parallel of COVID, but have been at least contemporaneous and probably accelerated because of the co-pandemic, and I think has some relevance for some of the work that we do here. I won't get to talk about it today, but I'll flag that I'm very interested in the narratives that whole genome sequencing is constructing for us. And we've had lots of, including a few of us online, I think, some interesting conversations about, the place that Foucault and others might play in how we understand the stories that we tell ourselves and who tells the stories around whole genome sequencing and the public health narratives that arise from it. So let me just bring up a couple of slides if I can get all this working. Great. Okay. So globally, all of us in TB had lots of concerns about the way that the COVID and TB epidemic might play out from very early on in the epidemic. And we've really strongly seen those play out in different ways around the world. Here we've worked as part of an international tracking study to look at one aspect of that, which has been TB notifications throughout the pandemic and the way services have been disrupted in a number of countries. And very consistently in almost all settings, what we found has been substantial decline in TB case numbers sustained over the last 2 years of COVID. Now, while there was a brief and overly optimistic suggestion in some places that factors like previous TB exposure or widespread BCG vaccination might have actually provided protection against COVID in countries like India, the later waves of really devastating COVID in those countries really put paid to that. And so overall, there's been very little evidence to suggest that TB and COVID interact very much in terms of disease susceptibility or risk of reactivation or other biological factors. Instead, what we saw was the impact of COVID on TB systems and structures and the way that these syndemics play out, particularly affecting along sociodemographic lines as well. And in terms of the structural factors, I'll just jump right in and highlight, I think, four summary factors that we saw very consistently disrupting services. The first was that TB programs were stripped of staff who were redirected to COVID work, including medical and nursing officers and epidemiologists and lab staff. So reducing, canceling TB clinics and follow-up programs. Now, this I'm sure has some overlap in the HIV space. A lot of these staff were disproportionately brought across because they were at least in a respiratory pathogen area. But I think it really disproportionately affected long-term programs. Because the services were prioritizing patients who were needing limited acute services. And even within TB, we saw priority given to the smaller number of active TB patients, whereas there was a lot of abandoning of case finding and preventative work across the community. The second thing was that in lots of countries, healthcare workers, of course, were disproportionately lost to the system entirely due to death or serious illness after contracting COVID within their work. And respiratory nursing staff were at particularly high risk of that in many settings, particularly where access to PPE was problematic. Third, we saw and we continue to see affecting us particularly at the moment interruptions to supply chain, which affected TB medications, diagnostic test materials, other key pieces of equipment that were needed to diagnose and treat TB effectively. Now, these three factors are probably pretty familiar to anyone who's been working in healthcare settings, either in Australia or around the world. But there was a fourth factor that is relatively unique to TB and I think worth emphasizing. And that's that over the last 15 years, TB services have adopted the use of a nested PCR platform called the Gene Expert as a primary diagnostic tool. These machines are really robust. We often see them in very rural and remote settings, often being run by solar panels, don't need much in the way of maintenance. And they were a huge advance over the long and difficult culture-based approaches to diagnosing TB. And so really have become a mainstay of TB diagnosis, particularly in areas where lab diagnostic facilities were lacking around the world. When COVID hit, though, very quickly, an alternative cartridge to go in these machines and diagnose COVID was developed. And suddenly, all of the TB infrastructure across the world was immediately co opted directly into the COVID response. And I mean, literally, my colleagues in countries that I won't name have told me about Ministry of Health trucks turning up to confiscate machines at gunpoint, or at the very least, requiring that only COVID samples could be run in these machines on site rather than being used for their traditional TB purposes. So undoubtedly, this was a major factor in reducing TB diagnoses. And our global estimates are that we've lost about 12 years of progress towards TB incidence reduction because of all these factors and because of the fact that every undiagnosed case of TB doesn't go away and just continues to transmit TB further into the community. So that's all happening on a global level. But what about here in Australia? Now, when we first started to recognize COVID as a significant pandemic, the Department of Health asked me if I could project the impact on TB epidemiology in Victoria. And what I said to them at the time was that I could see a range of factors that might have unpredictable impact overall. So, on one hand, mask wearing, social distancing, cessation of international travel, those are all things that might reduce TB importation and reduce risk of transmission within Victoria. Um, it might also be that concern about affecting healthcare settings where COVID was active or difficulty in accessing diagnostic services, just like we saw around the world, could lead to not a real reduction in cases, but a decrease in case numbers. Um, and so all of those things could lead us to have less TB cases to be thinking about, or less apparent TB cases. On the other hand, I can also see that home isolation could lead to increased intensity of household transmission in some circumstances, particularly when coupled with malnutrition and stress and vitamin D deficiency from being indoors in our at-risk groups, particularly in southern parts of Australia. And it might also be that the case that people who were presenting for respiratory infections, they might come in more quickly because of the pandemic focus. And so, another diagnostic, another way that people access a diagnostic service rather than staying at home for a month with the cough that lingers on. So all those factors seemed at least plausible, but it wasn't at all clear what was going to dominate. In the final equation, though, over the last 2 years, we've seen relatively steady, but overall about a 10% increase in TB case numbers. And when we drill down into that, most of that actually comes from something that I didn't predict at all in all of those factors, which is that a large proportion of that increase comes from older, predominantly Indian grandparents who normally would have visited for a month, but when lockdown started in Victoria, they came and stayed for a couple of years with their children. Now, presumably, most or all of these people would have developed TB back in India. They just wouldn't have been counted in Australian case numbers. But that's been, a very different sort of phenomenon that we've seen here from around the world. Beyond just case numbers, though, numbers are one thing, but TB services here have had a really significant qualitative impact from COVID. Our patient population, as I think people would be familiar with, is heavily flavored by migrants, international students, people on temporary work visas. And these are people who were disproportionately affected by COVID lockdowns, often unable to work and often not eligible for various government payments. So we as a program have frequently had to provide a lot of financial assistance for patients in pretty extreme circumstances sometimes. And we do that in the best of times, but it's really been unprecedented over the last couple of years. We've also had to change our model of care very significantly at times. From a disease that is transmissible that we would often admit to hospital to initiate therapy and prevent onwards transmission. Well, our hospitals have all been full of COVID. And so we've had to provide a lot of additional community-based care for people in their homes in circumstances that normally we would have had much more supervised and supported inpatient stays. It's been a really intense period of time for both our patients and for our staff. And so, in contrast with the global experience, I am very proud of the way that the service has been able to be maintained throughout, even though the models of care have had to change. Now, in the background, while all of this has been going on, there has been something of a revolution happening in Victorian TB public health. And I think the COVID focus has meant that this has not got as much notice as it might have been otherwise. And that's been to shift the way in which genomics is being used here in a much more detailed and integrated way than just a positive or negative gene expert result. COVID genomics, of course, has been very visible and it's been very valued in Australia. And that's also meant that the infrastructure for analysis and sharing sequence data and so forth between states has been prioritized. And so TB genomics has been able to piggyback on some of those developments, I think, to move this along a little more quickly than it might otherwise have. So previously in Australia, it was standard for all Australian jurisdictions to do a PCR confirmation of TB, to do culture-based looking at phenotypic drug susceptibility testing, and then to assess strain relatedness. Strains were historically compared using a variety of different methods that I'll skip over for this audience in too much detail. But to say that these are things that have led us to understand as we look at how related strains are across Victoria. We think of Australia as a pretty low transmission setting, and so this previous work can be summarized by suggesting that maybe about 4% of TB cases were clearly related to local transmission. Maybe about 10% overall had possible links to another case. So certainly the majority of TB cases being acquired overseas and reactivating here rather than being passed around in active transmission. Um, Over the years, a number of useful investigations highlighted the potential value for increasingly focused whole genome sequencing for looking at TB strain evaluation. And then in 2016, two of the largest jurisdictions in Australia started to replace the older techniques with routine whole genome sequencing. And that was done for a lot of reasons, including, I guess, from an AMR point of view, trying to get more rapid molecular diagnosis for drug resistance profiles that I'll come back to. But I wanted to say just a couple of things about how that's being used for the public health response at the moment. So, as I said, when we first introduced whole genome sequencing, it was done on this kind of unusual scenario. Selected isolates where highly detailed information might be a way to provide insights or scientific knowledge. But while that comes up with some interesting findings, we really realized pretty quickly that the real value of these sorts of techniques come from having routine evaluation of unselected isolates, because it gives us the most information about what's going on in the full public health landscape we're operating in, and allows the most timely input for public health responses. So now what we do is perform whole genome sequencing on every isolate, and then we have a multidisciplinary meeting every week with lab staff, epidemiologists, doctors, nursing contact tracers, to look at that information in real time and think about what additional public health information or response is appropriate. One of the big picture questions that we've been looking at was the extent to which unrecognized community transmission might be occurring. And so we wanted to start by having a closer look at transmission there. Here, I'll just quickly go through some of the findings from the first 4 years of implementation in Victoria, where of those, of nearly 1,900 cases of TB over this time, about 70% of them had fully sequenced isolates, and about 14% were clustered in some way. Highly related clusters, some just in the household, some in more disparate community settings. Now, we use a system for incorporating both the findings of whole genome sequencing and the information we get from interviewing people and the epidemiology of the cases to try to think about how confident we are in an association between two people who are linked by genomics. And so, for example, if we have a case of TB from 2016 that matches one in 2020, but the 2020 case only arrived in Australia in 2018, we may go back and say, look, local transmission couldn't have happened here. It's not epidemiologically possible. And so we can say that that transmission, at least, did not happen in Victoria. We might also have, as we often do, closely linked cases where there's no genomics available, which happens sometimes, for example, in small children who may not be able to cough up enough material for this sort of testing to happen, but it's clear that they've recently acquired infection from a known household contact. And so we use this matrix to bring all that information together and to try to paint the best picture we can of what's really going on. And following that investigation, about 11% of the cases were classified as resulting from likely or possible local transmission, which is pretty similar to what we had thought was the case. And so on one level, that's just reassuring to see that whole genome sequencing hasn't found a lot of unrecognized community transmission, doesn't tell us a radically different story at that top level number about what's happening in the community. Um, what I think is quite useful, though, is to move on from just thinking about those numbers to think about the context in which they're happening and the way that this is shifting the public health responses that we might need to have. Um, we traditionally have concentrated programs, as most have around the world, in households because there's the highest risk of exposure, the highest intensity of transmission, and so we recognizing that individual level risk. In practice, though, we found that the highest number of clustered cases were actually occurring in social groups outside of households. And if we look at this in more detail, this was actually especially in churches and other religious settings, which made up about a quarter of all clustered cases of TB in Victoria. Households were another 22%, but despite all of the epidemiologic contact tracing that we do here, there's still a decent proportion of cases that we couldn't link to a specific social setting. So still there remains some uncertainty and some questions that I won't go into more here about how far it's appropriate to press into a community and an individual's interrelationships to try to more closely establish links, particularly when two people don't obviously know each other before we start those investigations. Um, so while this analysis, replicated a lot of the things that we normally think of in terms of TB risk factors, finding this larger than expected range of social contacts and interactions there really sort of shifts for us a little bit about where it is that the effort of further expanded contact tracing might come, and particularly into these groups of people where the individual episode of connection might be, yes, lower risk, but overall the contribution that it's making to TB transmission and people's opportunities to be exposed to TB in Victoria becomes very significant. So it's really helping us to think about shifting our public health response to include a greater emphasis on the risk of community transmission beyond households. It is important to remember that household transmission, of course, is somewhat suppressed in our context already because of the efforts we go to interrupt it, to give people preventative therapy and so forth. But it seems to me that there's no really good reason why we can't translate those benefits into reduction in other groups as well. So beyond that sort of broad overview, we're also actively using whole genome sequencing in specific outbreak and cluster responses to help shape and guide our investigations. One quick example of that where it's helped us is that in 2007, we started to see a number of cases of TB occurring in people from a particular Pacific Island nation who were living in Melbourne. It started with a sentinel case of TB meningitis in a young child who'd never traveled overseas. And a recently arrived overseas visitor was found in our contact tracing to have previously unrecognized smear positive pulmonary TB. Now, this was a really challenging context to investigate. The infectious individual was found to have been living in multiple households, regularly attending formal and informal church services in enclosed indoor rooms. And the TB program did experience a great deal of reluctance from the extended community with regards to contact tracing and accepting preventative therapy. I, on one memorable occasion, had to give a sermon about TB, which was, I hope a helpful intervention in the grand scheme of things, but certainly gave an opportunity to meet a lot of people in context and, come to them with some of these discussions. Over the following months, though, but we did find a number of secondary cases that had these complex interactions in contact tracing, and it often wasn't particularly clear who had infected who and where the real risk was arising. Um, and then in the middle of all that, the whole genome sequencing of this data threw up something surprising. So a new TB case occurred in an adult who was born in a different country from everyone else on this list and living in a suburb that wasn't connected to the outbreak. So no known links, and it was a real surprise to us, thrown up just from the whole genome sequencing. This led us to a much more detailed, focused investigation for possible points of contact. And while I spent some time trying to convince Uber to release their passenger and driver records to see if I could match people to see if there was a particular link there. In the end, we did find that they had both visited as support people a GP clinic where they'd been sitting next to each other in the waiting room, and so that let us do further rounds of contact investigation and find some people who we could give preventative therapy to. Um, so, good outcome there in terms of in real time being able to feed this back. One one last thing here that I wanted to touch on is that while whole genome sequencing is providing, I think, these useful avenues for public health responses, given the topic today, I did want to bring it back beyond just the public health to be thinking about AMR. And the backdrop there is that there's also been very rapid changes in treatment for TB, particularly for MDR and XDR TB. Now, traditionally, MDR-TB therapy has been characterized by long, toxic, and pretty poorly effective therapies, generally involving at least 6 months of an injectable agent like amikacin at the beginning, and then up to 2 years of therapy. So this diagram here is a pretty traditional WHO-sanctioned approach that the details don't matter so much. But what we've seen over really just the last couple of years is rapid progress here. And over this period of time, we've moved from these highly toxic, a couple of years worth of therapy, such as we might have done, even when I started this a couple of years ago, through to an all oral regimen, which was still the same length of time, but avoided some of those toxicities and side effects, particularly because of new drugs like bedaquiline, which became available. And then in the last 12 months, having moved through several new regimens, such as Nix-TB here, which involves pretomanid, bedaquiline, linezolid. The key thing there being 3 drugs, all relatively new or repurposed for TB, and a 6-month total treatment regimen. Fair bit of toxicity associated with this regimen, but certainly short and certainly all oral. And now yes, and now in the last, really, this is since sort of June of this year that we've released the BPALM regimen, which uses a lower dose of linezolid and so has much less toxicity. But again, this is an all-oral regimen that we've now started using in Melbourne and around the world, really just in the last couple of months. Now, all of this is clearly great progress, and it's a great and positive outcome for people with MDR-TB to be getting effective therapy in 6 months rather than 20. But it does mean that an increasing proportion of TB patients will be receiving long courses of drugs like moxifloxacin and linezolid, which also have activity against a range of other human pathogens rather than some of our traditional TB drugs that are very TB specific. So while these other regimens aren't being used in Australia yet, there's globally also some jurisdictions that are pushing the envelope more with shorter courses of therapy using daily rifapentine and moxifloxacin for drug-sensitive disease. And given that over 10 million new cases of TB were actually notified last year, quite apart from the ones that I said we missed straight up, that's potentially a really large increase in long-term use of antimicrobials like these in the community. So it's definitely a space to continue watching for AMR monitoring and strategies to detect and reduce it. TB has traditionally mainly emphasized treatment success and prevention of transmission as programmatic outcomes, but there are moves to continue shortening TB treatment duration for many people. Um, and I think that other things that I won't say anything more about, like advances in therapeutic drug monitoring for optimal dosing, biomarkers for treatment success for early discontinuation of therapy, and potentially even the use of host genomics to allow optimal drug selection, will keep helping us to avoid adverse effects and treatment interruptions. They're all things that are under investigation, and I hope we'll circle back to helping us to have continuous, well-tolerated therapy that will reduce pressure towards antimicrobial resistance. So while that's jumped a little bit all over the place, I hope that gives you a little bit of a flavor of some of the things that have been happening in TB and COVID and AMR. And I think I'll finish there. Look forward to hearing from Alison and Lisa, and then how that Venn diagram comes together in a bit of conversation at the